So, good morning, everybody. It's really a great pleasure to introduce somebody I've known for too many years. Well, not too many years, but many years. Dr. Gordy Schiff and I were in medical school together. I was a few years older, but not smarter. And Gordy was kind of like one of the people who sort of introduced me to a lot of the issues around the politics of medicine. When I was in medical school, I was rather naive about this stuff, but he was kind of one of the mentors who I credit with sort of changing my view of, and sort of giving me a start in understanding some of the political background of medicine, and have been following some of the things that he's been doing for many years. He's a practicing general internist and Associate Director of Brigham and Women's Center for Patient Safety Research and Practice, Quality and Safety Director for the Harvard Medical School Center for Primary Care, and an Associate Professor of Medicine at Harvard Medical School. I'm going to just read his bio. He's published widely in the areas of medication and diagnosis safety, was a reviewer and contributor to the 2015 National Academy of Medicine report, Improving Diagnosis in Healthcare. He's PI of a recently completed 2-year project studying inpatient and outpatient diagnostic pitfalls, and was recently awarded a grant from the Gordon and Betty Moore Foundation to create a multifaceted research learning network to study and improve diagnosis and help develop principles for more appropriate and cost-effective diagnosis. He's received many awards, including the Arnold Gold Foundation for Medical Humanism to study professional patient boundaries and relationships. He's Associate Director of the Harvard course on best medical practices, maximizing skills, minimizing risks, and on the faculty of Harvard Safety Quality Informatics Leadership Program. He teaches in Harvard's Patient Safety Fellowship Program and is the author and editor of the Joint Commission's book, Getting Results, Reliably Communicating and Acting on Critical Test Results. He's recipient of the 2005 Institute of Medicine Chicago Patient Safety Leader of the Year Award and the Institute for Safe Medical Practices 2006 Lifetime Achievement Award. And in 2006, he was selected by Modern Healthcare as one of the 30 people of the future national leaders of healthcare most likely to continue to shape healthcare in the years and decades ahead. So it's a great pleasure to have you here. And just to say before he gets on that at the end, we have the privilege of having Gordy here for the morning. So for those of you who have some time and want to spend some time with us, we're going to be going over to 2006, and we're going to be hanging out just to sort of brainstorm and think about some of the critical things that are happening in primary care. And we'll have a few hours to kind of sit together. So any of you who have the time are welcome to join us and share whatever questions and issues you want to talk about. Thanks.
Well, thank you so much, Neil. I don't know, there's so many reasons I'm so thrilled to be here. Obviously, coming back, working with Neil for all those years previously, and we're sort of going to hopefully rekindle some of that in the next couple hours after this. Obviously, my son is actually Eugene in the audience and working in one of your health centers. He's a family medicine, wonderful doctor, serving, as you all are, the people that need healthcare the most. I'm a primary care doctor also. But really sort of the most important reason I'm so thrilled to be here is really the work that they're being done by you all in terms of the patients who need care the most. I do want to start with a story, and it really goes back to this era when we were medical students at Rush that Neil spoke about, and it really both taught stuff, we taught each other, we learned things, and hopefully we helped lots of patients' lives. But we exposed, this is the sort of the big medical center where we were medical students, the fact that patients were being segregated. The black and white women were delivering from two different buildings, and this is in the North in the 70s. This isn't like the South in the 50s or something. And we got this article published in the newspaper. The hospital was very upset about this. We just tried to talk about what the reality was. And we sort of we had what we called people's grand rounds. I guess you'd say we had a lot of chutzpah. We were first-year medical students and second-year, what we were trying to expose some of the problems. You can see institutional racism, sexism in healthcare. Again, this is 1972 or 3. Neil actually hadn't come to Rush. He came, so our group tried very hard to try to get something done. And again, you could see these, it ended with this speak out on obstetric and gynecology care where they actually, the nurses on the floors, many of them were the black nurses, and they really felt it was sort of unfair. They saw black patients being treated differently. And even some of them, it was supposed to be based on the insurance status. Some of them who had the insurance from the Rush were getting the, put in this older building and treated with the residents versus the private doctors. So we did home deliveries, and this again culminated in the speak out. And the net result of this, in terms of our efforts to integrate or desegregate the floors, was we didn't succeed. So we sort of got discouraged, and I guess if you don't succeed at first, Homer Simpson's advice is give up. But there's also other advice out there that sort of inspired us, and this is Rosa Parks. You should never be fearful if what you're doing is right. So obviously this idea about people integrating buses and not moving to the back of the buses, this was not just a single act of Rosa Parks, but it was a longer struggle that it was part of. And fortunately, we had a new person come to help train at Rush, and he started on the obstetrics floors. So this, hopefully you can still recognize Neil Kelman. This is actually Neil speaking. This is actually pictures from our wedding. So we found these pictures. And again, this is really a whole hour talk about this whole struggle to desegregate these obstetric beds. But basically, Neil was there, found actually research that was being done, unethical research without informed consent. The details are really a wonderful story. Whether it's Dr. Fidel was somebody who there were adverse outcomes from this research that was done only, again, on the public patients, quote, public patients, not on the private patients. And when we exposed this, Neil, again, leading that effort, the next week the OB floors were integrated, which we said really was a product of not just one bad researcher, but really a whole system that viewed patients differently, the public and the private, the black and the white patients differently. So here is Neil at our wedding, and I guess you could say this is one of the sort of black and white people dancing, celebrating, working together. This was one of the receptionists actually at the medical school, a dormitory where we stayed. And again, this is a very, I gather Neil still has all the musical genes and bugs going, and a great dancer, unlike me. But this is sort of a wonderful story that is sort of a preface to what we're going to be doing today here. So in terms of financial disclosures, I really don't have any. Some of these grants that Neil mentioned, and but this report, which Neil also alluded to, is something people really should be aware of. I don't know how many people are aware of this Diagnostic Error in Medicine report. Is it something people have read or seen? It's free online, the whole report, but the executive summary probably is worth, and we're going to touch on a number of the lessons and the principles, but we'd like to think that just like these earlier reports to Err is Human, this is something should really, and is really shaping medicine and changing the way we think about quality and diagnosis. But just starting from Massachusetts, which is where I work, there was a survey that was done. This is by this Betsy Lehman Center, which is a patient safety state agency. The residents were asked, have you been personally involved in a situation with medical error? You remember your family, and you can see a quarter of the people said yes. But the most interesting thing was, what are the types of errors that are being reported in this survey, this anonymous survey? People are spending their efforts on medication safety, et cetera, but look at diagnosis error. It really trumps, pardon the expression, the other, wrong surgery, medication errors, et cetera. And so we were in the beginning of the patient safety work. ARC awarded 93 grants for patient safety, and there was only one on diagnosis error. So here's the number one cause, and that was us, as a group of us at Rush and Cook County. And what we realized very quickly is why we were the only ones sort of foolish enough to wade out into this swamp, because it really is a little bit of a swamp about how you define a diagnosis error and measure it and agree about it. But having said that, this is a more recent, this is the National Patient Safety Foundation, IHI in Boston, but a national survey. Have you had an experience with a medical error? And then they included you personally or someone you knew. So it's really almost half the people when you just stop somebody on the street or at a cocktail party. And look at the leading one, misdiagnosis again. And again, here's another one, diagnosis didn't make sense, disrespectfully, et cetera. Providers spend too much time with the computer. That's not showing up so much, but you know, that's another leading one. And then a final sort of just give you a sense of the importance of this. This is primary care. This is purely, we went into all the primary care malpractice claims in Massachusetts. And again, this is a study we've published. And looked at all the closed claims. We had the two big malpractice insurers. Actually, they've never shared data or cooperated, Coveris and Crico, but we were able to bring all their data together. And there's basically roughly 100 malpractice cases a year against primary care doctors in Massachusetts. And 3/4 of them, so out of the 400 or 500 in 5 years, 500 plus, 400 are diagnosis. So it's not just the leading one by really a factor of like 6 to 1. Diagnosis errors are the dominant type of errors that people are filing malpractice suits about. And interestingly enough, you know, the types of cases that are problems is cancer is very high up here. Here's stroke, we may come to that in a second, but heart disease. But you look and it's again, these top 4, colorectal, lung, prostate, and breast. So a lot of these are not like zebras that people are missing. These are common cancers. And one of the more interesting parts of this, and it'll take me a second to sort of orient you to this, we looked at what happened with these cases, okay? And this is sort of just all the cases, all the non-general medicine, you know, non-diagnosis cases. And what usually happens, I mean, people talk about being sued and stuff, but mostly these things are dropped or dismissed. You know, somebody looks at it and they say the patient really doesn't have a strong case. It doesn't look like anybody did anything wrong. About 20% of them are settled. You know, if they go to trial, 1%, the plaintiff wins. So the patient wins, you know, 1%, the doctor wins 99% of the time, because often what they do is defensible and the defense, I'm sorry, it's 1 to 10. These are the ones that go to trial, excuse me, it's not. So it's by factor of 10 to 1. But look at the diagnosis, general medicine cases. 40% of them are settled. And what that means in kind of very simple terms is the lawyers look at this case and said, whoops, we can't defend. There was a nodule on that pulmonary chest x-ray. We can't really defend this case. Let's just settle. So twice as many of these have, I would call, preventable things that are in the chart. And again, even the ones that go to trial, twice as many, the plaintiff wins. But this is sort of striking that there's a lot of preventable things that are occurring under the hood of those diagnostic errors. This is the Coveris recently published some of their data. You know, what's going on a little bit with these diagnosis errors? And they say sort of clinical judgment dominates this. This is something I want to kind of both impress upon you and disagree with, because under the hood of this clinical judgment, there's a lot of things going on, and I think there's a lot of system factors. It's not just the doctor isn't thinking or being smart or wasn't remembering things the way they should have. But we're going to talk about this some more. You know, the way that they break this down is they call it a narrow diagnostic focus, so you really sort of stick with one diagnosis and don't have a broad enough differential. Testing wasn't done, misinterpretation of diagnostic studies. You know, and again, this is the radiologist could be misreading the x-ray, failure to adequately assess the patient's condition, failure to obtain a consult. And again, you can see, of course, these overlap with each other. So this is very recent data, hot off the press actually from a few months ago. I know we're speaking to residents here, and probably this is a good you know, hour or two that the residents should have a lecture, and actually all clinicians, about some of these what we call heuristics and biases. And you've probably heard these terms. And again, I'm not going to spend time on this, but be happy to do this and follow up. But you know, this whole idea about availability bias, you've seen something recently, so this is what comes to mind, and you give it disproportionate weight. Or this whole idea about confirmation bias, where you sort of search out things to confirm your initial hypothesis, or you know, you just anchor, you know, somebody's admitted from the emergency room with a certain diagnosis, and that diagnosis sticks with them. People don't rethink this. Hindsight bias. There's even another bias that I would also include on this list that I think you all probably are are probably more aware of than most doctors, and should be, because it's important. And again, for lack of a better term, I sort of call this a demographic or a stereotype bias, where you really, you have a generalized set of beliefs about women or minority, right? All minorities are drug users or criminals, or all these stereotypes that go around the media, but some of them are more implicit, that really actually may prejudice your diagnostic assessment. And like, for example, this is a book that was recently published. I think she's from New York, this Maya Dusenbury. You know, it turns out like brain tumors, for example, 1/3 of the women had to be seen by more than 5 doctors before they had a diagnosis of a brain tumor. So these first 4 doctors were missing. You know, somebody was coming in with headaches, nonspecific complaints. But this is twice the rate of men have to see so many doctors. And Crohn's disease, and it's interesting, my brother-in-law is in the audience here. I think someone in our family saw Dr. Crohn and had the diagnosis of Crohn's disease missed. This is at least a story we have in our family. But so Crohn himself missed Crohn's disease in some distant family relative a generation ago. But anyway, in Crohn's disease, and I don't know whether it was a man or a woman who they misdiagnosed, but it turns out it takes 20 months to make a diagnosis of Crohn's disease in a woman versus 12 months in men. Actually, both of them sort of would give you evidence that there's a diagnostic delay or error. Somebody's calling these something hemorrhoids, bleeding or something. But in any case, these are the kinds of biases that we sort of want to include in sort of our other list of traditional biases. So part of trying to learn about diagnostic error is that we went out and we collected, I guess this is still in the literature, the largest case series of diagnostic errors. And I went to grand rounds, audiences like this, and asked people to sort of share cases. They wrote them down. What was the error? What do they think happened? And again, we tried to understand this. And when we created a taxonomy that's still actually being used pretty widely, so what went wrong in the diagnostic process? They failed to consider the diagnosis. They didn't get a needed test. By the way, there's more than 500 things here because each case had multiple things that could have gone wrong. Erroneous reading of an x-ray, too much weight in a competing diagnosis, et cetera. Something in physical exam was failed to elicit or interpreted right. But again, you can say that one of them that's high on the list is failure to consider the diagnosis. We want to think about that. Again, is this just somebody thinking about the case and they just don't have a broad differential, that they never consider this? So in my view, and in fact, I really have never paused this lecture here, but I'd like to actually pause here and hear about some cases from you all. I actually just heard about one in the car from my son. If we don't get some from the audience, I'm going to put him on the spot for a second. But have you all seen any diagnostic error cases recently, or anything that's impressed on your mind? I guess I was told I should leave the podium here for the webcast, but so I'll stay here. But can anybody sort of come to the microphone and just share one case? We'll get 2 or 3 of these cases from your experience. Excellent.
I saw, this is a patient I saw yesterday in clinic, but who I've been seeing now for a number of months. She is a patient in whom an HIV diagnosis was missed for several months because she kept coming in with epigastric pain, and we kept thinking that it was gastritis and trying to treat her for that, and missed for several months esophageal candidiasis, which was the cause of her epigastric pain, until one of the doctors noticed the candidiasis in her mouth, started treating her for that, was like, I should probably also check and make sure that she doesn't have HIV, which she did in fact have. So she's now being treated with ART, is doing really well, no longer has thrush, but it was missed for almost a year. She saw at least 3 different providers in clinic, and I was one of them, and she's come back to me now because I'm one of the Compass HIV providers. Wow. But yeah.
So much rich stuff. Hang on for one sec.
Yeah,
so,
sure.
How do you think you failed to consider this, and what led you to finally sort of make the right diagnosis? What were the kind of factors? Anything you can share with us in retrospect?
Yeah, I mean, I think we see so many patients who come in with sort of this vague epigastric pain symptom who don't seem to have anything else going on, they see multiple providers as
That's not
this
the usual
patient
test when
did.
somebody has heartburn
Right,
or an
you know,
HIV
like,
test, right? Yeah.
exactly. There weren't, and at this point, you know, it seems like actually this patient probably had had HIV for quite some time. And so it also wasn't like prodromal symptoms where you would start to think about like, oh, there's other stuff going on. Maybe I should be doing broad testing. And every time you see a new provider, you're sort of starting a little bit from the notes, but a little bit from square one. And the first thing that you're going to think about is, you know, a gastritis or even an ulcer or something like that. So sort of starting from this, one of the things that we saw, you know, the availability bias of like, well, what's most common? Probably this is
And
irritation.
it may work the other way. Like the next person that comes in with heartburn, you say, oh, I wonder, this is probably HIV Candida. And, you know, you're going to sort of go off, right? Because it could work both ways, right? It vividly impressed on you. And but think about the Swiss cheese holes. It's a wonderful example. You know, first of all, they're talking about universal screening for HIV, right? Had that person fallen through the cracks?
This
and then-
was a
yeah.
patient who had consistently refused HIV testing in clinic.
Yeah, right. But
Until that day.
And again, if you get into this thing, well, it's the patient's fault or it's your fault, you didn't try and talk him into it, blah, blah, blah. But that doesn't really
No, I
lead
mean,
us
that's
to
not-
improvement. That's just
yeah.
a dead end, really thinking about what was her fear? Maybe she
I mean,
knew
it feels in retrospect like a hint,
yeah,
actually.
Right. So maybe she knew and she wasn't sharing the diagnosis, you know, so there's a lot of action under that hood. But then there's obviously the Candida, you know, did somebody
Yeah.
do a good oral exam on her and is the thrush evident in the mouth or not? You know, I mean, these are all interesting questions. And of course, when I said we waded out into the swamp of figuring out, we couldn't figure, did somebody make a diagnosis error that first time? Did they look in the mouth? Did they not? Was the thrush there? You know what I mean? Were the symptoms typical? So all these things, again, when you step out of the malpractice where everybody's got their gun drawn and the blame and trying to think, well, are there things we can learn for improvement? You know, it becomes a richer and more complex discussion. But actually the most important thing I'm learning is just how beautiful it is for you to share this with us. Thank you very much. When we ask these doctors, tell us about a case you saw personally or someone else, 2/3 of them were some other doctor did this. Okay? So
Oh,
for you
no,
to-
I
so
definitely
for you to be
was
sharing
the second, I think, person to miss it.
and sharing it publicly. So that's, you know, on one hand, we could say that's ho-hum and very fine and, you know, expected, but on the other hand, that's very special. Thank you. Yeah.
You're welcome. I'll say it's easier to share because she chose to come back to me anyway.
Yeah, right. And what if
That
she had
makes it
died
easier.
from this? You know, what if she had
Yeah.
perforated her esophagus and sued you? You know what I mean? Would you be standing up here feeling as comfortable sharing it or, you know?
Probably not.
Yeah, and a little more defensive about you didn't really do anything wrong in the beginning, you know, and nothing. Yeah,
You
right.
know, so
Yeah.
probably.
Yeah. Wow. I'm seeing, thank you. Yeah, and
This also want to come on you, so a lot of them have systems parts too, so there's the pressure of the, you know, the 15-minute visit and the resident has to see the patient and they have to precept the patient, they have to come to a conclusion, they have to come into the room with a plan. And I think there are all these systemic things that then put pressure
Yeah.
on a resident to come to a conclusion and perhaps have premature closure
Yeah.
or not to consider things broadly.
And how easy a fix is just to hit that button for a PPI, right? It's just, we got an easy answer. We don't have to get involved in all this other social history and denial of tests. You want to come? Yeah, all right, come on.
Okay. Matt Hayes.
You're
I'm
cutting
a-
into my lecture, of course.
Cool.
but
cool.
yes.
I'll try to be brief. No, a case came to mind. I'd love to hear your perspective. I'm a new faculty member. A couple of years ago, I had I'm the sports med guy. I had a collegiate pitcher, softball pitcher, who was having back pain. And that had gone on for about 4 to 6 months, low back pain. And it was thought to be mechanical. She had seen 2 other providers, and you know, I perused through the record. And anyway, I kind of went back and this is not to toot my own horn, but you know, I thought, all right, so it's mechanical back pain. Let's treat you with NSAIDs and do some exercises and things like that. And a week later, it didn't get better. So, you know, I was taught, hey, if you're doing basic stuff and it's not getting better, you know, re-examine the diagnosis. So you know, guidelines tell us if somebody has mechanical back pain, get, you know, don't do imaging right away.
6 weeks, 6 to 8 weeks.
Exactly. So so this was well beyond that. So I got
Choose wisely. Every
Yeah.
6 different societies say that. Yeah, I was suffering with my back pain for weeks and weeks. No, choose wisely. No imaging.
right. So but I did get plain films. Plain films were fine. Looked those over myself anyway, another week goes by, no response to conservative therapy. So I did order advanced imaging. She didn't have radicular symptoms, so it wasn't a great indication, but I was searching for a diagnosis and was astounded to find that they noticed that she had a massive splenomegaly that was coming all the way down into like L3. So that led to, obviously lots of different testing. It turned out that it was idiopathic splenomegaly, which is about 2% of cases. So there was really nothing to do about it. She didn't have her spleen taken out. She just had all the things that need to be done for splenomegaly. But the one thing that was interesting about it is that the other doctor that didn't do the imaging and treated her with prolotherapy, so he was using an alternative medicine for back pain, was jamming needles into her back. I decided, hey, I'm not going to confront him about this. I'm not going to say anything. We're just going to let it go. We all make mistakes. He got so angry with me. I mean, it led to a major riff in our little sports medicine department of 2 people, me and him.
Angry because you pursued all these testing things?
Exactly. He actually brought the patient in behind my back and saw her and confronted her. Why didn't you come back and see me? How did you end up with Dr. Hayes? It was a mess. So the narcissism, we know about that. I continued to try to just let it go. Eventually we did have a blow up, but we won't go there. But thanks for letting me share.
Wow. Again, this is not how we usually do this talk, but let me take advantage of. Thank you very much. So one thing is that this whole idea about sort of sharing diagnosis errors or confronting people about failures is not quite so easy as saying, you overrode a button about drug allergy, right? Or that there was a nurse gave it, I think it really. When you start saying you made a diagnosis error, that sort of cuts to the core of some fundamental pride and beliefs that everybody feels like they're a good diagnostician or wants to think that. So people get much more defensive about this, and it's maybe harder for learning. And also it's sort of less clear. I mean, did you do the right thing, ordering all these tests on somebody who had back pain for a short time? So, my insurer, my Blue Cross, penalizes me for every MRI I order of the back. I have my ratio of back pain over MRI. So I have a financial performance incentive to not order those MRIs. So as far as Blue Cross is concerned, you did a bad thing, right? Obviously, in terms of finding this thing, and it's sort of you could say it's such a weird incidentaloma, right? this large spleen. So there's so many issues that are raised here, but it's interesting, and certainly the patient's glad to be treated for the right diagnosis rather than the wrong diagnosis, right? But there was something that didn't seem right. You've seen a certain number of back pains, and this was kind of didn't smell right, didn't respond right, didn't sound right, right? I mean, it's hard to even know subjectively why did you do this, because I'm sure next week there's going to be 20 patients or a month. Patients with back pain you're not going to do this workup on. So, what are these kind of clues and red flags? Of course. If the person had fever or was a drug user, right, back pain, you start thinking about different things. Epidural abscess. We just went through a series of cases with epidural abscess missed. And that leads to people being paralyzed, right, if it's not recognized in a timely way. So anyway, Eugene, you want to share that one patient? Do you feel comfortable you mentioned? Or it's up to you. The CVA? Okay. Yeah, come and share for a second. Yeah. This is, again, my son, full disclosure. And again, this is another one where there's, so it's not clear what the right thing was. There's defensive-ness, but these are all cases that are worth us thinking about as we go forward, thinking more. Yeah.
Okay, we'll be quick. This was just a case, it was actually presented in our clinic staff meeting yesterday about a patient with slightly poorly controlled hypertension, maybe 160/90. And the emphasis was sort of to making sure people are being adequately treated for hypertension because it can lead to stroke or heart attacks. So I guess I saw a patient in late December who had been discharged from the hospital having a stroke, and they had been seen in the clinic a couple days before for a physical exam, but the time pressures, which I think we've already talked about, and just other things, like focusing in on the high blood pressure or the physical aspect of it, and not sort of recognizing, I guess, if someone's having some numbness or tingling in one side, it could be, a lot of people report that same kind of symptom, and then trying to figure out then, did we do anything wrong? I think this patient may have also been to an urgent care the same day that they came to our clinic for the physical, and that might have been the time, that day was when, if that was recognized the 2 days earlier, that they could go into the emergency room. But then the wife called the clinic the next day, and the nurse sort of appropriately triaged that question to say, you really have to go to the emergency room immediately, even though sort of the provider may or may not have realized that when they saw them the day before. So I don't think it's a question of like blame or anything. It's just maybe how do we learn from these things? And in the busy schedule that we all have, sometimes it's not always possible to talk to colleagues about every case and discuss these things in full. So there is a lot of learning to be done for all of us, no matter what how many years of experience we have, seeing patients, whether it's a few or none or 20, 30 years. I think we're all sort of subject to the same thing, as I can see from you, Dan. So
yeah. So here, a patient presented twice with these symptoms, right, and was missed or dismissed, and ended up having a stroke, maybe lost opportunity to have TPA. I don't know. Turns out somebody like David Toker Newman, who's now the president of our Society for Improving Diagnosis in Medicine, we have annual meetings on this, which I really recommend if anybody's gets interested in this. But he studies strokes. These are people who come to the emergency room with dizziness, and then they're sent home. You have the dizzies, and these people have strokes. And there's a lot of interesting research that's being done just on that one group of missed kind of strokes. But again, lots of issues from Eugene's case we won't get into. Who saw the patient, what they considered, et cetera. So, but as far as I'm concerned, a lot of these have to do with system problems. Or things are called cognitive problems, but did somebody not know certain ways, atypical ways these things can present? HIV can present atypically, strokes, inadequate time, not eliciting a key piece of physical exam. Do they not see the thrush in the mouth? Do they not do a good neurologic exam? Atypical ways, or rare things that threw people off, and sort of ask what are the causes, what are the remedies, and then there's EPIC, right? So this is a one case of Ebola in the United States that it was missed and the patient died. I don't know if people know about this or recall this, but the nurse elicited the history. The person had just returned from Africa where there was a heightened consciousness. We were screening everybody. It was there in the EPIC screen, and the doctor never saw that nurse's note. So of course, immediately they pointed to the EMR silo problem, and we know this from using this. And then of course, EPICs, lawyers came back at the hospital, and then the hospital said, no, it wasn't really EPIC, and it was anyway. But we can talk about that case more if you want. It was written up actually by some people from our society as well, Hardeep Singh. But this is the way I like to think about it. This is Don Berwick. This is one of my heroes. In fact, Neil introduced me with my bio, but really my bio is 35 years at Cook County Hospital. The last decade is all this Harvard stuff, but I'm just sort of been in the trenches. And one of the reasons I moved to Boston was to work with people like Don Berwick, sort of heroes who are doing quality improvement. And there's a quote of his. As I said, I just started doing this stuff in the early 2000s on Diagnostic era. He said, this is in the Boston Globe, a very famous medical journal, genius diagnosticians make great stories, but they don't make great health care. The idea is to make accuracy reliable, not heroic. And so this quote really sort of embodies this idea about, you could go to the great Dr. Schiff at Harvard and you can get the right diagnosis, and, brilliant people, although I've had already serious diagnosis missed on me by these great Harvard doctors, but that's not going to make great diagnostic accuracy as part of our system, as part of these 30 health centers or our larger health system. So we've tried to sort of rethink diagnosis in sort of a different way, a different paradigm. And I think the starting point, one of them is just this conceptual model that is in the Institute of Medicine report. They ended up putting in a much more complicated model, but to me, I can't grasp something too much more complicated than this. These 3 Venn diagram circles here. So on one hand, you have diagnostic process failures. So something is going wrong in the diagnostic process, and then you have missed and delayed diagnosis, and then of course you can have adverse outcomes. Okay, so what would this be? So let's say somebody has a blood sample switched, bed A, bed 122A and 122B, and the patient's sodium comes back, 118, and you look at this and you say, oh, their sodium was normal yesterday. Do they have hyponatremia, or is this some lab error and stuff? And then, then you repeat it and you realize you don't know why it was low, but that was the process error that went wrong. Okay, so you did make. Could this be hyponatremia? But then think about Linda McDougall, and I'm not violating patient confidentiality. She was on the cover of Newsweek. So she woke up after her breast cancer surgery. She had bilateral mastectomy, and the surgeon said, "You don't have breast cancer." And she said, "I'm so glad, doctor, you got it all out." And he said, "No, actually, you never had breast cancer. They mixed up the specimen, the initial biopsy with you and another patient." And so she had a bilateral mastectomy, so she had a wrong diagnosis of breast cancer and an adverse outcome as a result of that. And so you can see, and of course, people can fail to make a diagnosis when there's nothing really that's going wrong in the diagnostic process, or there's things going wrong all the time. I guess you could call these near misses that we could learn from. All sorts of, here's a test result that wasn't followed up, but no harm was done, et cetera. And so to be able to think about the diagnostic process this way, and we could put some of our cases, so like this HIV, esophageal candida, did they do an oral exam? Did they, take a good history? Maybe somebody didn't ask the question about, HIV risk, or in a sensitive way, or take the time to do that, or check old records. Maybe there's an HIV test sitting somewhere in the prior records. So, et cetera, or risk factors. So did things go wrong? Are there things that could have been done better? Obviously, there was a missed and delayed diagnosis. So the Institute of Medicine came up with these 8 goals for improving this, and again, partly because we spent time with hearing from you all. I'm not going to go into it in detail, but I'll just at least let you have heard of them. One is to better teamwork, people communicating better. I think we heard examples in some of these cases where people could be doing that, including the patient. The patient is part of the team. Professional education and learning about some of these biases and things that can go wrong. Health IT, getting the computers so they can support rather than make diagnosis harder. And we're going to talk more about that. Develop ways to learn from these things. So we sharing these cases. I mean, how many people heard about some of these cases that happen? They really aren't going too far. And these lessons, we shouldn't all have to make the same mistakes. A work system that supports improvements in the diagnostic process, and we're going to maybe talk a little bit about that. A reporting system, and so I've heard that we want to do better with reporting patient safety issues and learning from them, and they were in favor of this. Payment system that supports this. I think they drank a little bit of the Kool-Aid about managed care here. We can talk about that. And then funding research, yes, of course. So more than 1 out of 93 of these projects should be funded. As a researcher, I can get behind that. But I tried to boil this down into my own list of 5 practical suggestions that maybe we can try to ramp up in family health and how to do that. And the first one is, well, we'll just go through one, a culture of safety and how we improve that. We've alluded to this a little bit. Learning from errors, so figuring out how we're going to actually share these cases. Closed loop follow-up systems so things get actually followed up properly and the balls don't get dropped. Leveraging health IT to do a better job, making Epic work for us rather than against us, and getting patients involved in this whole effort as well. So let me just talk about this culture of diagnostic safety. They asked me to review an article, this is just a few months ago in the Journal of General Medicine, about they're coming up with these metrics. So the only way we're going to improve diagnostic things is create metrics and measure doctors. And I ended up, I'm not a big fan of a lot of these metrics. I think many of you aren't as well. And, I use these two quotes: not everything that counts can be counted, and not everything that can be counted counts. So a lot of what you do in terms of listening to patients and helping patients, talking to patients, you're not being, that doesn't count in your metrics, and it really kind of misses the boat. I'm sure there's an effort to try to rethink this and do this better in an enlightened organization like this, run by somebody like Neil. And then this is another quote from Don Berwick. People always say, he says you can't improve what you can't measure. Nonsense. Over the decades, my relationship with my wife has continuously improved. He's been married for over 40 years, as I have. Neil was at our wedding. But I've never administered a survey to her nor tracked metrics of our relationship. Not only was this not needed for improvement, but likely would have been detrimental and disrespectful. And of course, you can understand what he's talking about here. So what would a culture of diagnostic safety and improvement look like? So I tried to think about this in this editorial that I wrote. So number one, driving out fear. So people aren't afraid. If somebody screws up or learns of a diagnosis they missed, they're not afraid to share that. Or even when they don't know, I don't know what's going on with this patient, people really speaking up, and both when things go wrong and when there's uncertainty, an organization-wide commitment to learning from this. So number one, that the leadership knows that this is really actually a priority. If this is the top error that patients are reporting, then we ought to move this to the top of our list of things that we want to be improving. And I can guarantee you the board of Brigham, where I work, they don't think, they probably at the last 100 hours of board meetings, they probably haven't devoted one minute to thinking about diagnostic errors, even though the patients obviously are probably experiencing them. Reporting, investigating things that happen. So when these things come forward, file a safety report, fine. It goes into some black hole. Let's do something more. Curiosity, conferencing, and then assessment with details of the diagnostic process. What are all the things that can go wrong? Where the balls can drop? How can we tighten this up? Recognition that uncertainty is inherent. So we can make diagnosis, but the key is really the follow-up. Okay, so maybe this patient with this numbness and tingling that Eugene described is okay, but let's see what happens. And if it's something acute, let's follow him up in a very near term, okay? Let's see if people respond to the PPI or get better or worse. This is very important because there is a lot of uncertainty. Respecting human limitations, so make these EPIC screens so things don't get lost, that problems don't get lost, risk factors, et cetera. And then having the patient work collaboratively, because a lot of this is, people talk about consumers and producers, right? That's the market model for medicine. But it turns out this person, Julian Tudor Hart, do you know who Julian Tudor Hart is, Neil? Anybody know that name? People should write down his name. We got to actually meet him shortly before he died last year. He's a very visionary primary care doctor. Actually wrote a book called A New Kind of Primary Care in England. Anyway, he says patients co-produce diagnosis. It's not that the doctors produce diagnosis and the patients are the consumers, but we do this together with the patients. They have to come to us in a timely way and report their symptoms in an accurate way, right? If somebody knows they have an HIV test and it's positive, or their partner that they've been having a relationship with is HIV positive. By the way, this esophageal candidiasis patient, not only was it missed by the doctors, but how about the other sex partners for that intervening year if it was either known or not known? So there's even broader consequences to that failure of diagnosis in terms of transmission of HIV. Again, we've tried to develop this concept of diagnostic pitfalls. Can we take a group of these errors and learn disease-specific pitfalls and have some situational awareness? I put this in because of coming back to New York here. I'll talk about, but there's something called high reliability organizations, and they study these organizations where there's very low rates of accidents, nuclear submarines and even aircraft things. But people are really constantly worried about what can go wrong, appreciating, for example, knowing when the tests. So this person had an HIV test, but maybe it's negative in the first 2 weeks or something, or what's the role, or what's the sensitivity of, I look in somebody's mouth and there's no thrush, so I say, okay, you don't have oral candidiasis. So I don't know, I'm just raising that. Is that a sensitive test or a non-sensitive test? Is it specific? So if I see oral thrush, does that mean it's up and down the esophagus or not? So those are learning what tests, the limitations. And Perhaps the most important distinguishing feature of high reliability organizations is their collective preoccupation with the possibility of failure. They expect to make errors, so it's not like you made an error, you're out of here. We don't make mistakes in family health. We don't want you tolerate, zero tolerance. They expect to make errors, train their workforce to recognize and recover them. They continually rehearse familiar scenarios of failure and strive hard to imagine novel ones. Instead of isolating failures, they generalize them. Instead of making local repairs, they look, let's fix this one person who missed that stroke. They look for system reforms. So this is this plane, this Sullenberger, who landed in the Hudson, the U.S. Airways flight. People see the movie Sully? People must have seen that movie. There's some debate in the patient safety community. Does it make him into a hero, and is it not about systems? But anyway, it's an important thing. But I don't know how many people realize that morning before they took off, he was obsessed with safety, this guy. They had rehearsed a water landing. They'd gone through a checklist of what to do in a water landing of this plane. There had never been a water landing of a commercial, a domestic air flight previously. And that morning they had rehearsed what to do. And obviously, as you know, this thing sunk within minutes and everybody got off safely. And that was very impressive. So to anticipate things that could go wrong, so we've been trying to collect situations where there's pitfalls, where things could go wrong. And here's an example, like a sort of a simple one. So a woman that comes with a breast lump, and you palpate it, and you say, let's get a mammogram. And you get the mammogram, and the mammogram is normal. And you say, Mrs. So-and-so, your mammogram is normal, we won't worry about this breast lump. And some of those malpractice cases, a lot of them in the breast cancer in the earlier era, that's a pitfall. Someone should have known if there's a palpable lump, a mammogram does not rule out breast cancer. It's a screening test. When you have an mammogram, you say, no, nothing on your mammogram, please be reassured. But if somebody has a breast lump, that's a pitfall. You don't stop there. And so can we collect a series of these clinical examples, or heartburn that's refractory to PPIs, for example, in somebody so would these be known pitfalls that we could think of? And we really have collected these. We're going to hopefully start publishing some of these. And actually, we're going to put this in Harrison's Textbook of Medicine. So there's going to be a differential diagnosis and pathophysiology and diagnostic pitfalls. We're going to put in selected chapters. It's sort of exciting opportunity we have. But disease A mistakenly for disease B, okay? Failure to appreciate the limitations of the test. I'm going through these a little more quickly because of time. Just to get atypical presentation, okay? So strokes don't usually present with tingling in the finger, okay? But is that a possible way, and is it certain features we can do? Presuming a chronic disease accounts for new symptoms. So somebody has, rheumatoid arthritis and their knee swells up, so you're gonna call that, a flare of the rheumatoid arthritis when they have a septic knee or they have gout of their knee. Overlooking drug or other environmental causes. Again, these should be things that we should have high on our list because they're so preventable and reversible. You take away, the drug from the angioedema and their, ACE inhibitor. And or failure to monitoring. So somebody comes in, this back pain, okay, you can do the sort of conservative stuff, but it's not getting better. It's not responding as you want. And how can we create systems? Again, here's where we actually went through all the breast cancer cases as another round. And you can see here, false negative mammograms, 9 of these cases. This was, I think we had 36 cases that we went through. False negative, patient had fibrocystic disease, misread by the radiologist, et cetera. Even they went on to do ultrasound, and some of them false negative, so they falsely reassured the patient in that case. And sort of the way that I want to sort of have us think about this, and I don't know what to do with this. This is really a very schematic model. There's no numbers, there's no practical advice, but think about this. So you have red flag symptoms. So we heard about the back pain, right? With somebody has obviously weakness of their leg or fever or a high SED rate, okay? And then you have don't miss diagnoses, spinal epidural abscess. And by the way, I've seen 3 cases in my career, short career, of people paralyzed from this diagnosis. This is irreversible. This is something you don't want to miss, is spinal epidural abscess. But yet, that's all these needles in this haystack of low back pain. And then we have diagnostic pitfalls of things that are sort of patterns of things that people do wrong, that have made mistakes that we can learn from, and how can we sort of bring these all together to sort of increase our, what we call situational awareness, and like those high reliability organizations. Closed loop systems, just had a big grant that was turned down for this, but they said, what's the evidence that it makes a difference? So in medicine, we have an open loop system. Engineers would never tolerate this. So this is like the water goes on every day. This is lawn sprinkler, regardless of whether it's raining or the lawn is flooded, right? So you don't do that with a thermostat in your house, right? When the temperature goes up to 75, then it turns the heat off or the air conditioning. There's a feedback, there's a closed feedback system. So how are we learning about diagnosis errors and mistakes we made? Or are we just making these diagnoses and the people are going on, and then they see somebody else and they say, oh yeah, that Dr. Schiff, he's a dumb doctor. Yeah, he missed this, but do we ever call him on the phone? No, of course, he's gonna get upset. He'll say he didn't do anything wrong. So we just have this open loop system. Again, we've been trying to think about this for quite a while. We've done some stuff to try to close the loop, for example, on test results that are not followed up. So we did a randomized controlled trial with primary care practices in Massachusetts. And you can see this is an abnormal test result, and not in the chart. It turns out we sort of pulled these results from the electronic record. So this is, not surprisingly, it's not high. Abnormality not acknowledged. So 10% of the time there's an abnormal result. We looked at high TSHs and abnormal chest x-rays, and it's not acknowledged in the chart. Many cases, probably the doctor did tell the patient, but there's no evidence. If you were coming into a court of law, you could probably not defend yourself. And we actually didn't make a big difference. This is baseline and this is intervention. But the action plan documented improvement to that. Patient notified, again, 20% of the time, it doesn't say we told the patient, and we were able, again, to make significant action plan not completed. So you can see this shows both there's a ways to go, but we were able to make a difference by working. We had these practice improvement coaches and describe this. And then another one we try to do following up on patient symptoms. So we published this in JGIM. Turns out 16% of the people who came in for urgent care visits, we did this in 3 different clinics. One was actually a cerebral palsy clinic. This is in Alabama. We work with the University of Alabama folks. 16% had not improved, and 38% had never contacted the doctor. So I'm still having this cough, I'm still having this back pain, I'm still having this esophageal pain, and I'm not better, okay? You would like to say, well, you ought to come in, let's reevaluate, see what's going wrong. But in almost half the cases, there was no follow-up from that in terms of the patient getting back in touch. So we think this feedback has sort of a key role in patient safety. It emphasizes that really we're not certain. There has to be a differential diagnosis. Disease is dynamic. Maybe it's going to get worse, evolve over time. It conveys a message to the patient. We're not 100% certain. We're not perfect diagnosticians. We want to hear from you. We want to keep the door open, not, look, I told you this is just mechanical back pain. There's nothing wrong with you. Don't bother me anymore. We don't want to do that approach. And I'll just give you one example from something we did. A patient died of CMV, disseminated CMV, so we did an autopsy. It was, by the way, a lot of this took place under the umbrella of autopsies in the old days. We would get autopsies and we'd learn, 20% of those patients, we had things we'd missed, and those would be very important learning experiences where we're not doing autopsies. But here's a patient who'd been in the hospital for 2 months with fevers, and nobody could figure out what was going on, was treated for a lot of different things. It turns out they had disseminated CMV. They found this on autopsy. Unexpected or not previously diagnosed finding. And so we went back in the chart and we found 32 doctors who had cared for this person. And we're not talking about somebody who was ordered in the middle of the night, Tylenol for a fever or acetaminophen, right? These are people, this is the ID fellow who followed that patient for 2 weeks. This is the resident who had that patient on their service for a month. So these were people really involved in the care of this patient. Only 7 of the 32 had heard what happened. So someone was saying, I'm sure that patient must have had an atypical TB, and that was what I was betting my money. They never heard what really was wrong with the patient. Now that doesn't mean that every other patient in the hospital who has a fever has disseminated CMV. You have to calibrate this feedback in smart ways. But the fact that those doctors who were so involved in this patient had never heard what the outcome was, to me shows that we have sort of a broken, closed loop system. And then Again, this is something I would really like to spend much more time on, but let me just mention, we think clinical documentation, is this part of the problem or the solution? People talk about this is the paperwork to do after the job is done, CYA. But really, could we turn CYA into canvas for your assessment, where people are really thinking out loud and conveying this both for themselves and the next people to read the chart? Of course, it means it can't get buried in all this other garbage that's in the, in the EMR, all the checklists, the boilerplate things. And what do we mean by that? So thinking out loud about your differential diagnosis. When I say out loud, I actually just talked to Neil, are we using Dragon here? Should we be using Dragon or Scribes? This narrative, this thinking should be easy to throw in the charts. And we shouldn't have to type it in a very clunky way. And how can we do that? So we're going to be talking about that in the next couple hours, at least some of my thoughts. The likelihoods, this looks like, peripheral neuropathy. There's a small chance that it's a stroke, or what else could it be? What's causing this? So, even if I diagnose Candida esophagitis, that wasn't the underlying etiology in terms of HIV. So there's two diagnoses there. How urgent is? Okay, well, we'll treat them for a little while with some PPIs. It's not going to be life-threatening. That's different than a stroke or a sepsis patient. And how certain I am. I think this is nothing, or versus I'm really not sure what's going on with this patient. How can we convey this better and then act on these things to be able to document this? So we've gone through a whole series as a paper that you're welcome to read. Tools that can assist us in gathering some of this information and making it more visually displayed. Just think about the lab flow sheet where the abnormal is in red, right? Just cognitive displays where things don't get lost. Differential diagnosis generators, there are things that could do that. Let's list the possible causes and at least say we've considered this, or, I hadn't considered that in this case. Calculators for doing what we call Bayes' theorem and calculating pre-test and post-test probabilities based on the test. Getting a quick access to up-to-date, maybe up-to-date is our best diagnostic tool we have. You can get quick access to this. Ways of getting a specialist, you push a button. I don't know what this rash is, and there's a specialist who can tell you what it is or what the differential diagnosis, instead of going through big hurdles. This is something that actually is really implemented in Epic, in Cerner and Epic, where you can just start typing. A patient is a 30-year-old with target lesions in Eschar, and it starts generating a differential diagnosis here. Here's a close-up. And this is in real time. This is off of this Isabel. And you could say, theese are a lot of zebras here, but isn't this nice to be able to, just think about it here and see, gee, I hadn't considered this. So again, this picture is actually 5 years old, 4 or 5 years old. So this isn't like the future. This is real. And then the final one is working with patients. Again, I'm giving this short thrift, but here's for time, which this is the last slide. Patients first have to come in and see you, right, and give you reliable information. If I asked you to try a medicine and you have to take it, they say I didn't get better if they didn't take the medicine for the urine infection or for the PPI. It's hard to know what their hunch is. I think there's voodoo witchcraft that's causing my esophageal symptoms. Okay, you may not agree that that's true, but at least it's important for the patient to share that and you to know what their beliefs are. They can read on their own. Patients come in to me, I think I have lupus. I don't think there's anything that fits with lupus, but at least it's important for me to know, or, gee, I really hadn't thought about lupus in you. Then maybe that's a good thought. Being patient, respecting some of our limits, and working together, and actually getting involved with this patient safety, this diagnosis error society that I mentioned. We have lots of patients working with us. They come to these annual meetings and very involved. So what would it take at the provider and institutional level to help this flourish? So this is the end here. This is from New Orleans. Nothing about us without us is for us. So again, this is involving the patients, hearing this feedback from the patient. Sound like in Eugene's case, it was the patient's wife bringing this forward that really led at least to creating awareness that this diagnosis had been missed there, and maybe the clinic can learn something or improve off of that. So, okay, a couple of minutes for questions. I know we're over. Quick question, any thoughts, comments? Neil.
So how do we keep this from being, oh my God, I don't want to miss this, let's just order another test? Because I think it's not only the financial disincentive, but also we've developed this sort of culture of not rushing into sophisticated testing because, now we're sort of like hypercritical when people rush into getting an MRI or doing all of this stuff. So how do we, it seems to me like the quick answer to all of this stuff is, let's just order more stuff. So we make sure we don't miss the abscess. Maybe every back pain, the thing that we really don't want to miss is an abscess.
Right.
So we start ordering MRIs.
Right, and not just that, one of my paralyzed patients, they did order an MRI and it was a lumbar, and it turned out she had a thoracic. So we shouldn't just order lumbar, we should order the whole spine up and down, right? So I guess the short answer is you should invite me back. This is part 2 of this talk. And seriously, I just did these two as a 2-part thing. I hadn't really, at Mass General, we just did this for their quality people. We just published this paper, and I would really urge everybody, it's free online. The short one is in the Annals, and then there's the longer white paper. We really struggled with this, and the question is, are we going to err on the side of underdiagnosis, or are we going to swing the pendulum over to overdiagnosis? What we argue, and this is, I think, kind of a breakthrough in terms of my thinking about this, is that it's not that the pendulum we need a midpoint, that they're 2 sides of the same coin, that overdiagnosis and underdiagnosis. And how are we going to bring this together in terms of knowing our patients, following them better, learning the limitations of the test? The answer is really, the beginnings of the answer is here, and maybe we can talk about it in the next couple of hours. But I strongly would love to keep this as part of the whole conversation, because it can't just be, let's just start ordering lots of tests so we don't miss things. It has to be much more about listening to the patients, following the patients, knowing the patients, working together with systems, tightening up some of these places where balls can drop. Because with good follow-up, then we can, you don't have to order the MRI in that first exam. You can say the back pain's going to be better in 4 to 6 weeks, and we'll watch it together. And if we miss something, then we can pick it up then. So there's a whole series of ways that I'd like to think these 2 are related, and we can do better. I guess way in the back there, question.
So yeah, basically, it kind of touches on what you were saying. In terms of like overdiagnosing and underdiagnosing, I think one of the factors is, and as you were kind of mentioning, is time. Like, when you get to the point where you have like 15 visits and you're seeing multiple people, there is no time to actually sit at, and this may be coming from I'm still a resident, so I'm still struggling with this time issue, but I do think that it doesn't end, because just, visits get shorter and shorter the higher up you go. So is there any way we can, as doctors, sort of figure out how the people who are, paying us, because obviously the more visits you see, the more you get paid or whatever, the incentive system to sort of have time to be built into the system, to have time to look through the person's chart as long as whatever, think about their problem, and have time also to follow up after. Because a lot of people are curious and want to help people, but then if you don't have time to do that, it's just never going to happen.
Yeah. What's your name?
Toyin Alakija.
And Twyna?
Toyin.
Toyin. Okay, so afterwards, I want you to come up and get a CD. So anybody who brought a case forward, or a question, gets a free CD. So thank you for doing that. But of course, I don't have time to answer your question. So we have to, but really, this is one of these 10 principles that we really struggle with, right? Because time. So there's a song in here called "Time Waits for No One" by the Rolling Stones. Do you know that song, Neil? It's a great Rolling Stone song, so you'll get a copy of that, which we allude to that principle. Here's sort of the beginnings of the answer, okay? I would say this is just highest on the list of things we really are challenges and we have to struggle with, okay? The first one is, can we take as many things off the doctor's plate as possible? So instead of dealing with things like, did you have a mammogram in the last year or something? Somebody in a high school education could keep track of that, a cleric or the computers, right? There's a bunch of things that have to be taken off your plate. I think there's probably an effort to do that, but there's probably a lot more. So number one, let's create time, okay? Number two, let's harness time in terms of something that really comes from, is the essence of primary care, is called watchful waiting. Okay, so maybe we don't have to make that diagnosis today, okay? But can we engineer into our follow-up and feedback reliable systems for watchful waiting? Which might mean, okay, let's think about it. We're not going to solve this today. Let's see you in 2 weeks. I'm going to do some reading about this, okay? And then can we have more timely access and easy access to consultants or reference material, right? So let's read about this together about UpToDate, or let's go home and, they've done studies, doctors raise all these questions in the exam room and they say, I'm going to read about it, but they never do. So how can we create time for that? How can we create time? This is a half-hour patient. There's some patients that are 10-minute patients. How can we re-engineer in the scheduling to say, this is a complicated patient, I'm going to need a half hour, we just do this. Or maybe on the spot, adjust people's schedule with flow managers who can take your 2 walk-ins away, because this patient's turning out to be complicated, okay? So I think time, there has to be respect for clinicians' time that doesn't, in ways that don't exist. And we have to take exactly what you're saying and put that on, the top of somebody's priority. The way that often people in charge of these places, hopefully not the driving thing, is production pressure, right? That all we care about is getting our numbers up this year, okay? We're only seeing, 2.3 patients per hour. There's a national benchmark that says it should be 4.1. You're going to start seeing patients faster. We're going to load more people on your schedule. You're going to work harder. We're going to cut out the slack. When you have no-shows, we're going to make sure that slot gets filled in. That's not going to get us where we want to go. I mean, I think if you're seeing 2.1 patients, I forget what my number is, 2.3 patients an hour, that's how fast I can see patients under the current system and do a good job. And if you want me to see patients faster, or if you want me to do better quality with diagnosis, then you have to change the system to make it possible for me to do that. So it's not just a matter of people working harder or necessarily smarter as individuals, but thinking about ways of creating that time. So I absolutely agree. That's the perfect, I think, place to end this in terms of us running out of time. But I think that's not the answer. That's the direction we have to go to really make it better. And by the way, patients value having more time with doctors. That's their complaint. So we have to really work on that.